The American Heart Association has released a statement that he did receive defibrillation or a shock to his heart. He got prompt resuscitation or CPR. And I think that's really the reason that he's already left the hospital just a few days after cardiac arrest. And what we heard from the medical center was that he actually arrived there completely neurologically intact, and he was transferred out of the ICU in under a day. So really, really favorable prognosis that emphasizes the need for prompt bystander response systems, knowing how to use an AED, knowing how to deliver high quality CPR, because it literally can be the difference between life and death. And we know that out of hospital cardiac arrest, the prognosis is usually very poor. Only 1 out of 10 of them survive. And it's great to see him recover so quickly and recover really back without any signs of permanent organ damage or neurological sequela. It's fascinating because this is something that really has the medical and cardiology community a little bit confused about what is the best way to risk stratify these people, because they do tend to be somewhat higher risk. So, the athletes, just like everyone else, can have genetic substrates or arrhythmias that are undiagnosed, a hypertrophic cardiomyopathy, other conditions that set them up. But the fact that they're athletes puts a unique stress on their heart. So, we know that athletes can have remodeling of their cardiac chambers. So the sizes of the chambers, the way that they look, the way that they function can change in athletes. We know that they can have more interstitial fibrosis or scarring that can happen in the heart as a result of high levels of athletic training. We also know that when they're competing, their stress hormones, their catecholamines are really, really ramped up. And that can obviously precipitate an arrhythmia that can sort of set up an electrical short circuit in the heart because those stress hormones are so amped up. So it can be the perfect storm of not just having a genetic or underlying substrate, but then having all this athletic training on top of it that changes the way that the heart looks and sort of functions and the tissue itself. And then having those stress hormones really sort of precipitate that event. As a cardiologist, the first thing I want to know is the why, because the why makes all the difference in the world here. So when it comes to Damar Hamlin, for example, who had commotio cordis, which was just bad luck, so to speak. There was nothing structurally or electrically wrong with the heart. It was just the wrong timing of the chest trauma that set off his arrhythmia. That is an individual that I would feel comfortable returning to play. On the other hand, Bronny had a genetic predisposition like a long QT or short QT, which is the way that your heart's electricity resets can set you up for an arrhythmia. If you had a condition called hypertrophic cardiomyopathy, which is a genetic condition where the heart muscle gets too thick and too stiff, and you can also have arrhythmias with it. If he had any of his coronary arteries, the arteries that supply blood to the heart, going off in abnormal ways, that can cause you to have cardiac arrest during exercise, any of those types of things, it would be a whole different situation. We would be looking at a different trajectory. So I hope in the next few weeks and months, we do get a thorough examination on him, certainly an echocardiogram, possibly a cardiac MRI, but really further workup to help us determine why this happened. And that will really determine what the impact is going to be on his career. We've witnessed so many athletic arrests in the last few years that it really does make us more concerned as people, as parents, as potential athletes ourselves. So I would say sit down and talk to your doctor about what type of screening makes sense for you. And as I alluded to earlier, there's really debate within the medical community about what we should be doing for screening. There are countries like Denmark who don't screen anyone with anything as long as they're asymptomatic. Our own American Association of Family Physicians guidelines say that no athletic screening is necessary. On the other hand, the American Heart Association, the American College of Cardiology say at the very least, athletes should have a comprehensive history and physical, looking for family history, looking for predispositions, listening to hear if you have any kind of murmur or anything like that. But then there's certain guidelines, including the International Olympics Committee, for example, that will say that history and physical is not enough. You actually need to do ECG or EKG, which is an electrocardiogram, an electrical map of the heart to try to look for trouble as well. So really you see the spectrum from nothing at all to history and physical to his physical plus ECG and more screening. So we really are sort of divided on this. My personal take is, if you're an individual who's worried about your risk, go talk to your doctor and come up with a personalized plan that makes sense for you. What my practice is for my athletes, at the very least, I do history and physical, and I often do an EKG as well. Now, rolling out an EKG screening on a population level can have implications for false positives and false negatives. It can have implication for cost. It can have ethical implications because we're not screening non-athletes in the same way. So that's the reason some experts have been reluctant to do that. But I feel like these people are at a higher risk because of what they do and how their career essentially impacts their heart. And so we really need to pull out all the stops for their screenings.